So, welcome back to the third of the four lectures that we're going to be using to discuss disorders of the cardiovascular system. At the end of the last lecture, this was the slide that I was discussing, and I was really talking about the three different patterns of angina. So, stable, variant, and eventually unstable angina. So I talked about stable angina, what triggers it, what relieves it, what's the risk, variant angina, variant because it's unpredictable when compared to stable angina. The mechanism really doesn't appear to have anything to do with the presence of an atherosclerotic plaque, but more about spasming in the vasculature, the walls of the vasculature supplying the heart. So when you talk about a plaque, you can understand how that impedes blood flow. When you talk about a vasospasm, again, you're reducing the size of the lumen simply by a different mechanism, but the end result is the same. And what you want to do in this case is inhibit muscle contraction, which is what vasospasming does. And now we are going to continue our discussion of this topic by discussing unstable angina and myocardial infarction. Remember, we're talking about alterations in cardiac function, and really we're just looking at diseases of the heart vasculature. I'm going to remind you that the primary pathology for this, the primary pathogenesis of these diseases is atherosclerosis. And so what can result from that is unstable angina and myocardial infarct. Because the precipitating events that lead to unstable angina and myocardial infarct is the same in the initial instance, they're difficult to distinguish, and so oftentimes they're kind of treated together until a differential diagnosis is made. They share the commonality in the chest pain usually is when relative to stable angina. It's more severe, it tends to last longer. Typically, it's not relieved by rest. It can be a sudden thing. It can come on suddenly in an individual with no history of heart issues. Both conditions are life-threatening. This little flow chart that we see here really is designed to show you the steps that leads to unstable angina or myocardial infarct, depending on the severity of the issue. So the damaged plaque, again, it comes back to atherosclerosis. So the damaged plaque usually ruptures and exposes underlying thrombogenic substances. Think of things like collagen. So collagen can activate thrombocytes and coagulation factors, leading to a thrombus formation. And this thrombus formation can occur within minutes. And so remember, we're starting with a plaque that is already impinging on the size of the lumen. And now we've got a thrombus forming on top of that. And so with the thrombus formation, you get a further impeding of blood flow. And so you can get anywhere from that, from the lumen being partially blocked to it being completely blocked. And whether or not it's partially or completely blocked is what's going to distinguish between unstable angina and myocardial infarct. It presents the same way because you have a plaque and then you have a thrombus, and so you get a severe impeding of blood flow. So it presents the same way. So as we make our way through this part of the lecture, we'll talk about what are the tools that are available to healthcare professionals and cardiologists in particular that will help them distinguish between the two. So unstable angina, when you've got a partially blocked vasculature, and when you've got a complete occlusion, that usually is when you have a myocardial infarction. With unstable angina, you can usually kind of relieve the blockage before cell starts to die. But when you've got an occlusion, remember the heart really doesn't store any ATP, right? It's just relying on a constant supply of oxygen and glucose to make the ATP that it needs to keep doing its work. And so you can quickly lead to cell death, irreversible cell death with myocardial infarct. The problem with that is that those damaged cells are replaced by fibrotic tissue that lacks the ability to contract. And so you lose some of that contracting ability of the heart, and it doesn't regenerate very well. So you've got a plaque, the plaque ruptures, you got thrombus formation, and that's what precipitates the event. So how do we diagnose myocardial infarct? How do we distinguish between myocardial infarction and unstable angina? Well, there are three things that are used. We've got the signs and symptoms, we've got changes in the ECG, and then we've got serum biomarkers. And serum biomarkers will kind of lead the healthcare professional down the route of treatment. You can use things like cardiac catheterization, echo. You use to figure out what's going on. You can use a radionuclide scintigraph that can give you some information about what's happening in there. But a blood test is usually one of the easiest ways that you're able to distinguish between these different types of pathologies. So signs and symptoms: pain, of course, anginal pain, nausea, diaphoresis, vomiting. The pain tends to last longer. As I said, it's not relieved by the usual rest and nitrates. That's the more common signs and symptoms. Some myocardial infarcts may present atypically. You might have back pain, you might have abdominal discomfort. There's some evidence to suggest that it presents differently in women relative to men. Maybe it presents, we think it presents atypically, but given that for the most part, historically, most of these studies have been done in men, maybe that's the only, those were the first signs and symptoms recognized, and it's taking a minute for the community to sort of understand that the presentation in women can look differently. Sometimes you may have small asymptomatic myocardial infarcts. That is problematic because they start to build on each other over the years, and that can eventually lead to heart failure, right? So you've got the typical signs and symptoms of infarction, changes in the ECG. So the ECG, right, is a snapshot of the electrical activity that's associated with a single heartbeat. And so you've got these peaks and you've got these sort of intervening segments. You've got the P wave, the QRS complex ventricular depolarization, and the T waves. And so when we look at myocardial infarct or unstable angina that results from ischemia, we may see things like ST segment depression. So ST segment, I'm not going to go over this again. If you want a refresher, I refer you back to what you would have learned in A&P 1107. So that segment can be depressed. You can have a T wave inversion. The T wave is ventricular repolarization, or you can have that ST segment being elevated, right? And all of those can tell the cardiologist something about the type of issue that the patient is having. The ST segment elevation, this is the sort of problematic and kind of waves a big red flag, because it tells the cardiologist that the injury is acute and sometimes the ischemia is still ongoing. So with an ST segment elevation, really there's a need for immediate action. We might see a T wave inversion or an ST segment depression in some cases. In that instance, the treating physician or the treating cardiologist, they will have a little bit more time in terms of their treatment protocol, because it says that the patient is at risk for a huge problem, but they've got a little bit more time to sort of deal with it. So we've got the signs and symptoms, we've got the ECG changes, and the third tool that's used to make a differential diagnosis is serum biomarkers. All right. So cardiomyocytes contain specific isoforms of things like creatine kinase MB, troponin 1, or troponin I, or troponin T. Remember, those are all part of muscle and they're used in muscle contraction. And so what happens with a myocardial infarct? Myocardial infarct, or heart attack, as it's more commonly known, that oftentimes lead to cell death. And so when the cells die, the cell membrane breaks down. And so the breakdown of that membrane allows the content of the cell to spill into the blood. And so what you will see then is with myocardial infarction, you may see an increase in things like myoglobin, in troponin, in lactate dehydrogenase, in creatine kinase. So we see here is the precipitating event We're looking at time or hours after onset, and we're looking at the changes in these markers within the bloodstream. So a simple blood test to measure for these markers can tell the healthcare professional, if he suspects there's an infarction, whether or not it's ongoing or whether or not the individual has had an infarction. Right. So we've got myoglobin that kind of peaks, and look at how high it goes up, right? It peaks quickly, right? And it decreases quite quickly. The myoglobin is less specific than the other markers because you can get myoglobin from other sources. The troponin, right? That peaks, it stays up a little bit longer, right? And it peaks at the same time as CKMB, right? But the level of troponin remains a little higher, a little bit longer. This serum marker, right, is the most specific of the three, CKMB, right? And this is a highly specific marker, and so if you sort of are able to measure the level of this particular protein within 24 to 48 hours after the onset, you can see whether or not there's been myocardial cell damage, and that will tell the healthcare professional something about what's going on. So given that we've got this sort of commonality between unstable angina and myocardial infarct, we can see an elevation in the ST segment, we can see depression in the ST segment. How does the cardiologist make a distinction and a definitive diagnosis as to what's going on? Right? So this little tool is what is used to make a diagnosis or a definitive diagnosis. Right. So we've got a patient, right? So let's say you are the nurse or you're the doctor on call in the emergency department. The patient presents, they're complaining of chest pains, they're a bit pale, they're sweating, they may be experiencing nausea, they may be complaining of abdominal pain, and so you suspect that this person has some sort of acute coronary syndrome. Remember, acute coronary syndrome covers unstable angina and myocardial infarct. Initial presentation is the same, and so you need to make a differential diagnosis to determine whether this patient has unstable angina or they're experiencing a heart attack, because that's going to determine the ultimate treatment for this patient. Usually the first thing that's going to happen is that they're going to hook that patient up to the ECG machine, right? The ECG machine will make the first sort of separation. If there's an ST segment elevation, you can pretty much be assured that the patient is experiencing what is called a STEMI. A STEMI simply means ST segment elevation myocardial infarct, right? So you can pretty much know that this person is having a myocardial infarct. You will eventually send off their blood to be tested for biomarkers, but that is going to lead you down one course of treatment. So what happens in the other instance if there's no ST segment elevation, right? That doesn't tell you anything, right? Because it can either be what is known as an NSTEMI, a non-ST segment elevation myocardial infarct. They're still having a myocardial infarction. It's just not as serious or doesn't need as acute intervention as if there's a STEMI, right? But it can also be unstable angina, right? So how do you know what's the difference, right? The other thing that is common between these two cases is that you might not see an ST segment elevation, but both of them can present with ST segment depression, and both of them can present with T wave inversion, right? So in this instant, just the ECG alone is not sufficient to allow you to make a definitive diagnosis. The next step is to do a blood test and to check for the serum biomarkers, right? If the serum biomarkers are present, then we have what is called a STEMI, right? So if the serum biomarkers are absent, then we know that the patient is experiencing what is known as unstable angina. And it's this little tool that is used oftentimes to help make a definitive diagnosis. If you've got ST segment elevation, usually you'll see the presence of biomarkers. and you know the patient is having what is called a STEMI or ST segment elevated myocardial infarction. That usually means that the injury is acute, it can be ongoing, and that it's significant, and that you have to get in there and do something immediately. You have a little more time if there's no ST segment elevation. The patient is still having a significant cardiac event, but you have a little more time in which to deal with it, right? So when you have ST segment elevation, acute reperfusion therapy, that means you're trying to get the blood flow back as quickly as possible. You might be treating with clot busters. If it's unstable angina, then you've got a little more time, right? PCI is just where you insert a catheter into the coronary arteries, and then you might do interventions to open up the occluded artery. So you can do things like removing the thrombus, trying to disrupt the plaque, or you can place stents in there, right? The whole point of this next slide is to give you an idea of how the myocardium is affected. So what you're looking at, this structure represents the myocardium. On the inside is the endothelium or the endocardium. That's the lumen that we're seeing. You've got, sorry, that's not the lumen. What you're seeing here is the coronary artery. And then this is the heart, sorry, your coronary artery, and here you've got a thrombus being formed. This is what it looks like with unstable angina. We're looking, trying to compare unstable angina versus non-STEMI and STEMI. What's the point of this? The point of this is to show you how much of the thickness of the heart wall is going to be affected based on how much blood flow has been disrupted. Right? So we can have an acute occlusion. We're talking here about a thrombus. Everybody has a plaque. Somehow the plaque's been ruptured. The thrombus is forming, right? So the thickness of the heart wall that will be affected will be dependent on blood flow, right? The relative workload of the heart and how long that flow is interrupted. So with unstable angina, we may see what is called an ischemic zone right here, but you're seeing there really isn't any damage, right? So you may have gotten in there, you may have gotten to the plaque before any damage was caused. With a non-STEMI, right, there is maybe some a little more significant damage than you see, but you may not have necrosis or cell death. The myocardium is a little bit more affected, right? But again, you've gotten in there in time to relieve the blockage, and then you might have recovery with a STEMI now. It's the entire thickness of the heart wall that has been affected in terms of its access to a blood flow. So the idea is that ultimately the size of the tissue that experiences the infarction will depend on how much the blood flow has been interrupted, how long the blood flow has been interrupted, and that extent and duration of blood flow determines the level of severity of the ischemia. So when you see the entire thickness of the wall has been affected, what can result from that is a STEMI, right? That's a significant cardiac event. You need immediate intervention. The compensatory mechanisms are the same. It's really geared towards retaining or sustaining cardiac outputs. And if you look at them, it's the sympathetic nervous system, it's vasoconstriction, it's fluid retention, very similar to what we saw for heart failure and how the body responds to try to maintain cardiac output. You're increasing heart rate and contractility, you're enhancing preload, and that can lead to, in the short term, maintenance of cardiac output. But over the long term, again, you might have hypertrophy and remodeling, which can lead to heart failure. So again, I want you to keep in mind as we go through this and as we're making our way through this, really all the heart is trying to do is to maintain adequate cardiac output. Anything that disrupts its ability to maintain cardiac output will kind of trigger compensatory mechanisms to try to improve or to restore cardiac output. The consequences or complications that can result from an infarction will depend on which vessel is being blocked. You can have impaired contractility, electrical instability, tissue death, an inflammation of the pericardial sac, and depending on which of these where the blockage is, you can see some of the consequences. If you think, for example, if there's an infarction in the conduction system, that can lead to arrhythmia. If you have a large enough area of the muscle that becomes infarct, and that you have cell death, and then you've got non-functional cardiomyocytes, that can lead to heart failure, congestive heart failure. If you've got the left ventricle being the area of infarction, that can lead to heart failure again with pulmonary congestion. Now we understand how that happens. And in addition to pulmonary congestion, there's going to be decreased forward flow. If the infarction is in the right coronary artery, for example, if the blockage, is in the right coronary artery, then you would have signs and symptoms of right heart failure. What about if the papillary muscles is where the area of infarction takes place? What do the papillary muscles do? They anchor the leaflets of the valves, and so if you've got papillary muscles that are no longer functioning properly, what you can have what is called acute mitral regurgitation, and that can lead to congestive heart failure. We'll see that, I think, in the next topic that we discuss. Let's think about infarction in the walls of the left ventricle. So if it's in the septum, for example, if you have an infarction in the ventricular septum, right, that can lead to a ventricular septal defect. We'll talk about ventricular septal defects when we discuss congenital heart diseases. What if the infarction is in the free wall, for example, of the left ventricle? Then that defect can lead to a breakdown of the ventricular wall, and that can lead to bleeding into the pericardial sac, and that can lead to cardiac tamponade, right, because of a rupture in the wall. So the complications, the potential complications are varied, and it really comes down to the area of infarction, how severe that infarction is, and that will determine what are some of the potential complications. And quickly, just in terms of treatment before we move on, what are the treatment goals? Really, you want to minimize how long ischemia is taking place, and you want to prevent it from happening again, right? So you want to decrease workload, you want to increase myocardial oxygen supply. Again, there's that economics of supply and demand, right? And these are some of the things you can do to decrease the workload. You can decrease your preload, decrease your heart rate, decrease your afterload. You want to release the pain. You want to sort of tamper down the sympathetic nervous system, because that just causes the heart to speed up, which puts more of a work burden on the heart. And then to increase the supply, you want to get rid of the blockage. That's all that's happening, right? Because usually ischemia is because of a blockage, and so you want to take care of that. And then you want to sort of managing any recurring symptoms. If you've got an arrhythmia, oftentimes people that end up with pacemakers, it's because they've had an infarction that may have disrupted their intrinsic conduction system, and so they have a pacemaker that's going there. And so you want to take things like adjuvant therapy to sort of make sure that atherosclerosis doesn't spread. So lipid lowering drugs and changing, if you're sedentary, becoming a little more active, watching what you eat, right? So you want to control the things that are under the sort of that modifying column to try to mitigate some of the consequences or the potential consequences of a potentially other myocardial event. Wow, that was so difficult to get that sentence out. I don't know why. Anyway, the idea is that you want to find things, you want to monitor it, and you want to manage it, and you want to intervene as quickly as you can. To wrap up coronary syndromes, I'm just going to mention two other things that we've kind of mentioned before. Chronic ischemic cardiomyopathy, right? So we haven't discussed cardiomyopathy. We're going to get into that. But ischemia can lead to damage to the heart wall. It's chronic, which means it happens or develops slowly over time. So you might be having these small sort of interruptions in blood flow, and they don't precipitate a big event, so you don't even know it's there. But with time, it kind of builds on one another. It's the idea of sort of, the building contractions until you get to tetany, right? And so it builds on other. And so eventually, after many, many years, potentially that can lead to heart failure, right? This type of cardiomyopathy is slow, and oftentimes it may be silent. And so the patient might say, might have kind of, just general kind of not feeling well, non-specific symptoms. They may feel slightly fatigued. They may or may not be short of breath. They may have, this feeling of general unease. You say, I'm not feeling well, but I can't quite pinpoint what's going on, right? And so that might be only symptoms, and you may brush it off, right? And then it kind of builds over time until it leads to death. And then another syndrome, sudden cardiac death or sudden cardiac arrest. Sudden cardiac death really is where you see the individual dies within an hour of a cardiac event, usually because of a dysrhythmia, ventricular dysrhythmia, and we'll talk about that when we get to looking at some of the pathologies associated with the intrinsic conduction system. But a sudden cardiac death as a result of ventricular dysrhythmia, its prevalence has dropped significantly, because now when you look around, when you go to places like hockey arenas and most public buildings, there are these external defibrillators, right? And so because of the increasing in the number of people that are trained in CPR and the use of these defibrillators, right, these deaths as a result of ventricular fibrillation, its prevalence has gone down, but it does fall under coronary syndromes. Okay, so that was diseases of the heart vasculature and some of the consequences of those diseases. Mainly, we're talking about unstable angina and myocardial infarct. Now we're going to turn to what happens when there is a problem with the valves. So you've got four main valves. So you've got the left and right AV valve, and then you've got the pulmonary valve and the aortic valve, right? So the left AV valve, or the mitral valve, or the bicuspid valve, and the aortic valves, that's where we're going to be focusing on, because it's the left side of the heart that does most of the work, right? And problems with the valve can manifest as heart failure. So that's why I introduced heart failure, and we're coming back and we're looking at all these diseases that can precipitate heart failure. What can cause valve damage? It can be congenital. You could get stiffening of the valves. You can get inflammation or scarring, right? And they can change the way blood flows. Usually they open and they close. They're silent when they're open, and you hear the heart sounds, S1 and S2 when they close, right? When they don't open or close properly, you get abnormal heart sounds, and they're called murmurs, right? And we will see how when they don't open or close properly, we will see how that can lead to heart failure, right? There really are just two pathologies when it comes to valve disorders: stenosis and insufficiency. Stenosis means stiffening. A stenotic valve doesn't open properly, right? And that creates extra pressure for the heart, right? So if it's not opening properly, you're going to need extra pressure to force that blood through that smaller opening that's created by the stenotic valve. Usually the heart compensates by undergoing hypertrophy, but as I've said again, hypertrophy in the short term is a good thing, but in the long term, it can lead to heart failure. The other type of pathology that we will see with valves is insufficiency, right? And so insufficiency refers to an inability to close properly. So when do valves close, right? So think about when your AV valve closes and opens. think about when your semilunar valves or your pulmonary and aortic valve closes and opens. And so if it doesn't close properly, when one of the sets of chambers of the heart contracts, rather than forcing the blood in a forward direction, what's going to happen is some of that blood will flow backwards or regurgitate back into the chamber from which it just came, right? And so those are the two types of pathologies that we're going to be looking at. Again, we're still in chapter 18. Stenosis and regurgitation can happen on the right side of the heart or on the left side of the heart. We will focus on what's happening with the left side of the heart, but be aware you can have the same type of pathologies on the right side of the heart. I'm not going to discuss this slide, right? But I find this slide is very interesting because sometimes you think to yourself, well, how can a cardiologist just listen to what's happening with your heart and they hear a heart murmur, and how do they know what's going on, right? The links, and I think they work, I've checked them that I've put here, helps you to understand or helps you to hear the difference in heart sounds that happens when you've got a mitral stenosis or mitral regurgitation, or aortic stenosis or aortic regurgitation. So if you click on the link, I will encourage you to listen to the normal heart sound first. So remember, there's usually two. S1, which is the closure of the AV valves. When do the AV valves close? The AV valves close at the start of ventricular systole, right? And the S2, which is the closure of the semilunar valves. When do the semilunar valves close? The semilunar valves close at the beginning of ventricular diastole, when the ventricle starts to relax. So listen and then hear the distinct sounds that are made when there's a problem with the valve. So I'm going to leave that up to you. I'm not going to ask you to identify those sounds on an exam, but it's just for your own information to help you to appreciate how different things can sound like. What I'm going to do is I'm going to go through aortic stenosis and aortic regurgitation and explain sort of the steps you have to go in analyzing what happens. And then I'm just going to mention mitral stenosis and mitral regurgitation. And that's something I'm going to leave you to work through on your own in the interest of time, right? So what's going to guide our discussion of aortic stenosis, right? Patients with aortic stenosis can feel weak and fatigued, and the question is why, right? So what you're looking at here, and you'll see this in the next 4 slides, we've got a picture representing the heart, so it's a section through the heart, and there's a circle usually surrounding the valve that's under discussion on that slide. In our case, we're looking at the left side of the heart. For the next 4 slides. The left side of the heart, remember, deals with oxygenated blood and pumping it, receiving it from pulmonary circulation and pumping it out into systemic circulation. And this is the exit point, right? We've got the aortic valve here. A stenotic valve is a valve that has stiffened, and I've said a stenotic valve has problems opening. In terms of aortic stenosis, what can cause it to become stenosed? Aging, a congenital anomaly. You can have rheumatic heart disease. You can have any number of things leading to that, right? That is not our concern. Let's just, our starting position is that for whatever reasons, this valve has become stenotic. And so the question you're asking yourself is, what is the effect on blood flow? What's the effect on blood flow? What are the consequences for the left side of the heart? What are the consequences for peripheral circulation as a whole? So we start off with critical aortic stenosis. So what does that mean? When the left ventricle contracts, it has to overcome the afterload, right? To force that valve open. But if the valve is stenosed, right, you're going to have increased resistance. So you can think of it one way as you're going to have a huge increase in the afterload. So that's the back pressure that the left ventricle is going to have to overcome to force or eject that blood. All right. So as that pressure increases, again, what happens to muscles when you stress it? Think of lifting weights, right? When you lift weights, your muscles increase. So what's going to happen is that with time, the left ventricle is going to undergo hypertrophy, right? Again, I've said that hypertrophy can lead to remodeling, and then eventually in decreased contractility. This is what's going to happen with time, right? So initially, it's going to get bigger to do this, but it can't maintain that increased workload for an extended period of time. After a while, it takes a toll. Think of lifting, I don't know, whatever amount of weight, non-stop, 24/7, let's say 20 pounds, just non-stop, 24/7, without interruption. That's what your heart is going to be doing, right? After a while, in initial instance, it's going to start to grow, but after a while, it's just going to become tired. And so it's going to sort of give up and just lose its ability to contract, right? So what is happening with this stenotic valve? It's increasing the pressure that the left ventricle is going to be facing, right? So if the pressure on the left ventricle is going to increase, what's going to happen is that it's not going to be able to eject. It's not going to be able to eject its full stroke volume. So some of it is going to back up here. And then what's going to eventually happen is that backup will eventually translate to what the left atria is doing. Right? There's going to be increased pressure in the left atria because think about what's happening. Closed circuit, 2 side-by-side pumps, right? If you've got a higher than normal residual volume remaining in your left ventricle, the incoming blood from pulmonary circulation, it has a reduced amount of space. So some of that will again remain in the left atria, and that is going to affect the blood that's coming in this case from pulmonary circulation. So you're going to have a backup in pulmonary circulation. What does that sound like? Left-sided heart failure. Remember we talked about, why it backs up. That can lead to pulmonary edema, and you see the same signs and symptoms: dyspnea, orthopnea, coughing, because you've got pulmonary congestion because of a problem all the way downstream from your pulmonary circulation, right? In terms of the forward effects, our stroke volume is lower than normal, right? What do we have? We have a decrease in cardiac output simply because the left ventricle can't force enough blood through this stenosed aortic valve. So a decrease in cardiac output, a decrease in the perfusion of your systemic tissues, tissue ischemia, reduced blood flow, and then all the things that are associated with that. Pain, because again, not only with systemic tissues not have enough blood to meet their needs, but your heart also, right? Because your heart samples the blood that comes off of the first set of blood that comes out through the aorta, right? So you got angina, not enough blood to the brain, underperfusion of the kidney, and not enough blood to the brain can lead to stroke, right? So you've got forward effects and backwards effects, very similar to heart failure, right? If you've got a critical stenosis, so it's become stiffened and hardened, you might precipitate the formation of a thrombus, and that can also lead to these consequences, right? So the question is, why does a patient with aortic stenosis feel weak and fatigued? The answer is there's a decreased cardiac output because of a problem with the outflow tract of the heart, and so the tissues are underperfused, and if you've got an underperfused tissue, you're not getting enough oxygenated blood to make enough ATP to meet your body's needs. Why does the left ventricle undergo hypertrophy? It really is just to overcome what is essentially an increase in the afterload, right? So that's what's happening with a stenotic aortic valve. What about a regurgitant valve? So again, we're looking at a slice through the heart, right? Now our aortic valve is fine, right? It's not stenosis. It opens fine. It closes fine. That's it. We're looking at, actually, no, it's not fine. It opens fine. It just doesn't close properly, right? We're still looking at the aortic valve, right? It's our bicuspid valves that's fine. We're still looking at the aortic valve. So now it opens fine, right? But it just doesn't close properly. Why is it important for the aortic valve to close properly? So what happens when the left ventricle contracts, right? So it contracts, it ejects its stroke volume of blood, it relaxes, the pressure starts to go down. As the pressure starts to drop, in a healthy individual, the blood in the aorta starts to flow backwards. It gets caught in the cusp of the aortic valve and it forces it shut, right? That's what happens in a healthy individual, right? But in a regurgitant aortic valve, some of the blood will flow back downwards into the left ventricle, right? Because it doesn't close properly. And so the question becomes, right, how does that affect the functioning of the heart? So again, let's work our way through this very nice schematic that we see here, and we're going to come back and try to understand what's going on over here, right? What's being shown in this graph is what's known as a widened pulse pressure, and this is one of the hallmarks of aortic regurgitation. So we've got a regurgitant valve, the blood leaks back into the left ventricle. That is going to happen during diastole, right? Because it's when the blood flows backwards, that's when the problem is going to happen. So if we're just looking, let's just focus on what's happening with the left ventricle. We've got blood flowing back from the aorta into the left ventricle. And at the same time, because now we're in diastole, we've got blood flowing into the left ventricle, the normal complement of blood that will come from pulmonary circulation. This is the oxygenated blood through the left atria and into the left ventricle. So you've got two sources of blood now flowing into the left ventricle. And so the net result of that is going to be increased left ventricle end diastolic volume, right? This is going to cause the walls of the left ventricle to stretch because it's got this huge amount of blood in there. And eventually it's going to lose its contractility, right? So what happens every time this left ventricle contracts and the aortic valve fails to close properly, right? It means then that some of the blood that was meant to be part of the stroke volume is flowing back into the left ventricle. So the stroke volume goes down. What is cardiac output? Heart rate times stroke volume. So your cardiac output goes down and you see the same sorts of consequences as we saw for aortic stenosis, right? That's what happens in the forward effects. In the backwards effect, right, we are going to increase pressure on the left atria. Why? Because you've got blood flowing backwards, and that blood that is regurgitating into the left ventricle, it's going to take up the space that would normally be available for blood that's coming from the left atria, right? And so eventually what's going to happen is that some of the blood is going to remain in the left atria. That is going to back up into pulmonary circulation. And again, you see you've got pulmonary edema and you get the same signs and symptoms, right? So this is reminiscent of heart failure. That's why I did heart failure first, right? One of the forward effects of aortic regurgitation is what's called a widened pulse pressure, right? What is your pulse pressure? Your pulse pressure, if you remember, is the systolic pressure minus the diastolic pressure, right? The green here is normally what you see. The red is with is what you see with an aortic valve that's regurgitant. So a widened pulse pressure, what does that mean? It means that your systolic pressure is higher than normal and your diastolic pressure is lower than normal, right? So let's think about this. As the blood flows back into the left ventricle during diastole, right, the diastolic pressure, which is the pressure that we're going to be measuring in the aorta, is going to drop. Because remember what happens when the blood, so let's just pause and think about this. When the left ventricle contracts, it shoots that stroke volume into the aorta. Your aorta is an elastic artery. It's going to stretch and expand to accept that blood. As the ventricle relaxes, the pressure is going to start to drop, and that blood is going to say, okay, I want to flow back. Because remember, flow occurs from an area of high pressure to a low pressure. But as it starts to flow backwards, those valves are going to kick into gear normally and stop it, right? So you're going to have that diastolic pressure in the aorta, and as the aorta starts to recoil, it's going to push that blood forward. What's going to happen as it pushes that blood forward is that the pressure in the aorta is going to eventually decrease. But what happens with regurgitation is that some of that blood flows back into the ventricles. And so yes, the pressure is going to fall, but it's going to fall lower than normal because some of the blood has regurgitated into the left ventricle. The systolic pressure, right, it's going to increase, and one of the reasons it's going to increase is because you have a higher than normal blood volume, right? So when you sort of squirt that out, your stroke volume is going to go out. So your systolic pressure is going to be higher than normal. So your systolic pressure is higher than normal. Your diastolic pressure is lower than normal. So when you do your pulse pressure, which is the difference between the two, you're going to have a widened or a larger than normal pulse pressure, right? So when we think about what's happening, right, if you think about aortic stenosis, the problem is in systole, right? So when it's systolic and it's supposed to eject through the aortic valve, that's hindered, right? With a regurgitant aortic valve, the problem occurs during diastole because as the heart relaxes, the blood flows backwards. The next two slides, I'm going to leave you to do them on your own, following the same train of analysis. It's very, very similar, right? So mitral stenosis, right? The problem is during diastole, right? And then we've got mitral regurgitation. It occurs during systole. And if you sort of work your way through that, you will be able to sort of understand why that is as you make your way through these two slides. Okay, so disorders of the heart wall, we're going to transition now from looking at heart valves, and now we're going to look at diseases of the heart muscle itself. And this is just a reminder of the layers of the heart wall. I'm not going to go over it. We're just going to jump right into it and talk about pericarditis, pericardial effusion, myocarditis, and cardiomyopathy to sort of get us through this particular section. So carditis is an inflammation of any layer of the heart, right? Carditis. Pericarditis has to do with an inflammation of the pericardium. So if I go back, right, and we look at the heart wall, here's the fibrous pericardium. Pericarditis is the inflammation of that area, right? The cause, it can be infection, it can be idiopathic. Usually what you get is chest pain. And why do you experience chest pain? It's from as a result of what's called a friction rub, right? And a friction rub is kind of like, I don't know what's the word to describe. It's kind of like a grating sound that you hear when you listen to the heart with a stethoscope. And it's because that inflammation causes what is normally a smooth and lubricated layers to slide against each other, and it causes it to become rough. And so you get this kind of a grating sound that is made, that is very characteristic of pericarditis. The pain is affected by position. It tends to get better when the patient leans forward and worse when the patient lies down. Why is that, right? What happens when the patient is lying down? When you're lying down, the heart and the pericardium are more compressed and stretched in a horizontal position. And so they're rubbing against each other, and that can increase the level of pain. In some cases, pericarditis can lead to pericardial effusion, which is an accumulation of fluid in the pericardial sac, right? And if that accumulation is large and sudden, the individual develops what is called a cardiac tamponade, right? Tamponade simply refers to, what is tamponade? An external compression of the heart chambers. And that external compression actually impedes the filling or impairs the filling of the heart. Right? And I've put this in here to help you sort of appreciate what's going on. So we've got a higher than normal volume of fluid around the heart, and that is going to compress the heart, because remember, the pericardium is this fibrous sac and it doesn't have much give to it, right? It doesn't have a lot of elastic tissues there, and so it's going to compress the heart. What does that mean? It means that the heart cannot relax as much as it normally would when it's filling, and so we can't expand properly to fill. And if it's not filling, again, closed circuit, 2 side-by-side pumps, if it can't go where it's supposed to be, it's going to back up somewhere, right? So we're going to get back up into systemic circulation. What you're going to have happening then is decreased blood flow to the lungs, and you can have a decreased cardiac output because of this buildup of fluid around the heart, right? That's compressing the heart. There are 3 signs that are usually characteristic of cardiac tamponade, and they're called Beck's triad. One is hypotension. Why would that lead to hypotension? What determines your blood pressure? Your blood pressure is going to be determined to some extent by your ejection fraction and your stroke volume. So because there's decreased forward flow from the left side of the heart, then you're going to have hypotension. Jugular vein distension, that's another of the classic signs of cardiac tamponade. It's also a sign of right-sided heart failure. And so that's because of backup in systemic circulation. And remember, your jugular veins have a direct route to your superior vena cava. And so if it can't flow there, it's going to back up in your jugular vein. And then muffled or distal or distant heart sounds. And it's simply a muffling of the normal S1, S2 sounds because of the fluid in the pericardium, right? So I said here, what is the effect on stroke volume, on heart rate, right? So if it can't fill I'm going to give you a hint, right? If it can't fill properly, then what is the effect that it's going to have on heart rate, on stroke volume? And with respect to heart rate, what are the things that the heart is trying to, what is the one thing that the heart is trying to do all the time? All right, is to maintain cardiac output. And so the heart rate, right, what happens to the heart rate is going to be dependent, or you have to think about the compensatory mechanisms that usually kicks into gear. So that question should be fairly straightforward to answer. All right, so myocardial diseases. So that was the pericardium. We're going to talk about inflammatory and non-inflammatory myocardial diseases. And so myocardium, we're talking about the heart muscle itself, right? So it's the part of the heart that when it contracts, when it undergoes systole, it generates the force to move blood forward in a healthy individual. If it's the right side, it's the force that's going to push the blood into pulmonary circulation. If it's the left side, it's the force that needs to overcome the afterload, force the blood into the aorta and push it forward into systemic circulation, right? So you can have inflammation, right? Inflammation of the heart muscle that can lead to necrosis. Necrosis is simply cell death and degeneration. And again, remember, once the heart muscle dies, and it's replaced by fibrotic tissue, it loses its contracting ability. And if the heart can't contract, then really it's not functional, right? And its ability to pump blood becomes severely compromised. I've listed some of the causes, potential causes of inflammation, but these sort of main characteristics, right, or the most important consequence is it's an interruption or an impeding of its inability to pump blood. Myocarditis can be acute, where the symptoms develop quickly and resolve shortly after onset. So think of things like a viral infection. Acute myocarditis can usually occurs in teenagers and infants, but it can occur in every age. And then you can have chronic myocarditis, where it takes longer to develop, right? And the signs and symptoms can be reoccurring. Chronic myocarditis are what is going to result from conditions like autoimmune disorders, where the immune system can attack the cells and tissues. The inflammation develops as localized lesions, and then you have this sort of prolonged dealing with signs and symptoms, right? The result can be left ventricular dysfunction, which is severely problematic, right? The heart muscle can look like it's swollen, or it's just got a fluid accumulating in there. Your endocardial structure, so your endothelium and your valves, may look healthy. It's just the muscle that's affected. Right. And again, we're looking at these signs and symptoms: pain or tightness of the chest because it's not pumping efficiently. The heart is in an oxygen deficit, so you might start to experience angina type pain, fatigue. Now we've talked about that over and over again. Irregular heart rhythms, as the heart tends to tries to compensate, right? But if this becomes severe, it can lead to heart failure. And then heart failure can lead to a complete collapsing of the pumping system, and that is quite significant. So this is inflammatory type myocardial disease. And then we've got cardiomyopathy, which is the non-inflammatory type diseases of the heart muscle. What is cardiomyopathy? It really is the term that's used to define a group of diseases that affect the myocardium, right? There's usually structural changes in the heart muscle itself. You can have impaired systolic or diastolic function, and it usually occurs in the absence of other heart disorders, right? Usually in the absence of coronary artery disease or valve disease or congenital diseases, which we haven't talked about yet, right? So in terms of its etiological classification, clinically we talk about primary or secondary cardiomyopathy. The primary cardiomyopathy, these are disorders that are confined to the myocardium itself, so just the heart muscle itself. Many of them are idiopathic. Some of them may be genetic, others are acquired. And then you can have things like secondary cardiomyopathy. So it's cardiomyopathy as a result of something else, just as all secondary types of pathologies are. Right? So you might have hypertension leading to cardiomyopathy. You might have ischemia leading to cardiomyopathy. You might have inherited disorders leading to cardiomyopathy, right? So usually what you see in secondary cardiomyopathies, right, you will see the heart is affected, but usually there are other diseases that are in play in this particular scenario. The diagram that you see here are the three types of cardiomyopathies that we're going to be talking about: dilated, hypertrophic, and restrictive. And so we're going to be addressing those as we discuss cardiomyopathies, right? So really the overriding question we're trying to answer so that we can understand the signs and symptoms that we see right? Two questions to keep in mind. What happens to blood flow if the musculature of the heart thickens or stiffens? You're going to have two different things there. And what happens to blood flow if it thins out, right? The morphological classification, usually it's based on the left ventricle, is what we see here. So this is our comparator. This is our standard. We have a normal looking heart right here, right? These are the three types of cardiomyopathies that we're going to see. We're going to talk a little bit about, right? They're categorized as dilated to dilate. We talk about vasodilation and vasoconstriction, same idea. Dilate simply means you're getting bigger. That's not necessarily a good thing, and it's particularly not a good thing in this instance, right? Hypertrophic, thicker, big, hypertrophy, right? We talked about the left ventricle undergoing hypertrophy with aortic valve stenosis, and it's undergoing hypertrophy. Restrictive simply means stiffening, right? And so those are the morphological classifications, and I've put below here what's going on, right? So in terms of understanding the clinical manifestations that result from either a dilated, a hypertrophic, or a restrictive cardiomyopathy, really we're thinking about, when we think about this, we have to think about what the ventricles are doing, because realistically, if you think about blood flow through the heart, right, the ventricles just need to relax and they're going to be filled by 80-85% of their end diastolic volume. The contraction of the atria just forces the remaining 15 to 20% in. So most of the filling takes place within the ventricles, right? So if you think about what the ventricles need to do, right, they must relax during diastole when they're accepting blood, and they must contract during systole when they're ejecting blood. So what we're going to be considering is how does the change in the morphology of the ventricle affect those two functions, its ability to relax and its ability to contract. And that's going to help us understand some of the signs and symptoms that we see as a result of changes in the musculature of the wall. Again, I've listed some of the signs and symptoms here: dyspnea, orthopnea, impaired exercise tolerance, etc., etc. Most of them you can track back to either valve disease or heart failure to see how they develop. Dyspnea is always going to result. Dyspnea, orthopnea is always going to be a result of, pulmonary edema, right? Fatigue is always going to be a result of an impairment of cardiac output. So I'm not going to go over them again, right? So we're just going to start and look at hypertrophic cardiomyopathy. Hypertrophy simply means increased growth, right? So with hypertrophic cardiomyopathy, I've pulled this off the internet to sort of give you an idea. This is an exaggerated sort of representation of hypertrophic cardiomyopathy, but it's essentially selective thickening of the left ventricular wall with particular thickening of the ventricular septum, such that it can get to the point where it impedes the outflow tract. So the outflow tract is the path for the blood out of the left ventricle into the aorta, right? It's a genetic disease, right, caused by some of the sarcomere proteins. We're not going to get into the details of that. But if you think just generally and you ask yourself the question, what circumstances make muscles grow bigger and stronger, right? It's hard work, right? So if you want to think of genetic disease, if you want to think of something else that can make the left ventricle grow bigger and stronger, you're going to think about what circumstances can increase the workload of the muscle, right? The left ventricle is working against the afterload. The afterload is the back pressure, right, that it has to overcome to eject its stroke volume of blood. So an increase in blood pressure can increase the strain or the work that the left heart has to do, right? How about aortic stenosis that we just discussed? That can increase the workload. That does increase the workload of the left ventricle, and that can increase the muscle size of the left ventricle, because the ventricle will have to squeeze to force against that resistance, right? You can ask yourself the same question about the right side of the heart, right? So what types of resistance would cause the right ventricle to work harder? Think of pulmonary hypertension, which we talked about, all right? Pulmonary hypertension as a result of left-sided heart failure or as a result of mitral valve failure, right? Pulmonary valve stenosis. So anyway, we're looking at this. We're talking about a disorder, a genetic disorder, right? And so in this cases, I said 25% of cases, we've got a thickening of the outflow tract. And you would look at it and you would think, were it not for this thickening, you would think, great, right? My left ventricle wall is thicker. It means it can generate more force. It'll just be more efficient, right? And that is true, right? But one of the things that you have to realize that comes with the thickening is that if you look here, you see a reduction in the size of the chamber, right? So that is the flip side of that. Sorry, excuse me. Right? So that thickened left ventricular wall means that it can't relax. The chamber size is smaller, so it's able to accept less. So you're going to have decreased filling and you're going to have decreased cardiac output, right? And this type of cardiomyopathy is the most common cause of sudden cardiac death in young athletes. And the reason for that is that as these athletes, and these are usually high performance athletes, as they increase their level of physical activity, what's happening? The workload or demand, remember supply and demand, right? So the demand, the workload on the heart increases. And usually what happens is that the heart needs to work harder to try to keep up with this demand. And strenuous activity, one of the things that it can do is that it may precipitate or it may enhance this outflow tract obstruction, right? And that will severely reduce the stroke volume, and that can lead to sudden death, right? So the thickening, yes, you might think, oh, well, that's good. But then again, you have to consider the totality of what that thickening means. And so that the fact that the volume, the filling volume is smaller is problematic. So this may be asymptomatic, and some of the symptoms may be dyspnea and angina. And I've asked why. What is angina? Chest pain. What causes chest pain? Decrease in blood flow to the heart. So to figure out the answer, right, you have to ask yourself, what does a hypertrophied heart do better than a normal heart, and what does it do worse? It may pump better, right, but it fills less. And if it fills less, then your cardiac output would decrease there. All right. So with dilated cardiomyopathy, we've gone to the opposite end of the spectrum. So whereas the hypertrophied heart is thick and strong, the dilated heart is just big and baggy and flabby, right? And so you've got an increase in the chamber size. And so you may be thinking, okay, so the left ventricle size has increased significantly. Great. We've got a bigger end diastolic volume. So when it contracts, the cardiac output would be higher, right? And so it won't need to contract as often to just meet the metabolic needs. But again, there's a flip side to that. This increase in the size of the chamber comes at the expense of the thickness of the ventricular wall. And so because the wall is thinner, it can't generate as much force. Right? So it has a problem contracting. So even though it has a bigger end diastolic volume, because it doesn't have the force necessary to push that out, right, your cardiac output still decreases. So I've defined it here, right? It most commonly results from ischemic heart disease or valve disease. So the end result of a problem with your blood vessel, the end result of a problem with your heart valves is dilated cardiomyopathy. And when you look at dilated cardiomyopathy, it looks very similar to heart failure, right? This is the type of disease that develops slowly over time, right? And you might see very few symptoms until the heart is slowly slipping into failure because of impaired systolic function, right? So when we talk about the hypertrophied heart, it couldn't relax. With a dilated heart, it has a problem contracting. And so how would the ejection fraction be affected? If it has a problem contracting again, your ejection fraction would be decreased. And so you will see some of the general signs and symptoms of heart failure again. And you should be able to work out, now that we've talked about this over and over again, you should be able to work out, for example, why dilated cardiomyopathy leads to pulmonary congestion, right? Or why it leads to eventually leads to pedal edema. And it's the same sort of line of reasoning that we talked about with heart failure, that we talked about with valve disease. It's the same line of reasoning that comes into play, right? So this one is a systolic dysfunction. I've asked a question here, which imaging techniques would be best to confirm this diagnosis? And this should be a really easy question, right? Think, what does an ECG tell you? What does an echo tell you? What does an MRI tell you? What does angioplasty tell you? So just think, angiography tell you. So just think of that and think of what you would want to know about this and which imaging techniques you would use to determine that. Right. And then the last one, restrictive cardiomyopathy. This is the rarest of the three forms of non-inflammatory myocardial diseases. Idiopathic again, or usually in conjunction with other conditions. In hypertrophic, we had a thickened left ventricle. In dilated, you can have all four chambers dilated, but usually it starts with the left ventricle dilation. In this particular case, it's fibrotic, right? So it's stiffened, right? So if it's stiff, right, what's going to happen if it's a little bit stiffer? The problem will be relaxing enough to allow proper filling to end up with a proper end diastolic volume for ejection to take place, right? So when we're looking at it here, we've got a stiffening of the vasculature. So that's the first thing. All right. So you've got impaired filling. If you've got impaired filling, your end diastolic volume is lower. And so your less blood is available to be pumped into systemic circulation. And so if you're not filling properly, again, it's backing up somewhere. Closed circuit, two side-by-side pumps, it's got to back up somewhere, right? And so if less blood is being ejected, you've got a low stroke volume. And if you've got a low stroke volume, your tissues, including the heart, can become under-perfused, right? And the most common clinical manifestation of restrictive cardiomyopathy is right heart failure with systemic venous congestion, right? Again, we've got things like exercise intolerance, dyspnea, and weakness may be present. And these symptoms will develop the same way. So to work out why someone with restrictive cardiomyopathy may be dyspneic, you just have to think about how, right, you will get pulmonary congestion as a result of what's happening here. All right. So just to summarize what we've just talked about in terms of diseases of the heart muscle, we talked about pericarditis, pericardial effusion that can lead to pericardial tamponade, myocarditis, and then we talked about the cardiomyopathies, dilated, hypertrophic, restricted. These are the morphological representations of what that looks like. And so I've just summarized here what the changes in the chamber volume, compliance. What is compliance? Compliance simply means how easily a chamber of the heart or the lumen of a blood vessel expands when it's being filled with a volume of blood, right? That's all compliance mean. What happens to the contractility and what's the eventual end result of these different cardiomyopathies. So with dilated, the volume is increased because the compliance is increased, but the contractility is decreased. Eventually, you get left-sided heart failure, right? With hypertrophic, the volume is decreased, particularly in the left ventricle. The compliance is decreased because of the thickened muscle. The contractility is normal, right? You don't have a problem with contracting. But again, left-sided heart failure can be the eventual result. Why? Because this hypertrophic heart eventually loses its ability to contract. With restrictive, it looks very much like hypertrophic in that the volume can be decreased. The compliance is decreased because it's generally stiffened. Normally, the contractility is fine, but it may change with time. And the end result is right-sided heart failure. Right? And so how are these diagnosed? We diagnose them. We've got tests like echo, cardiac MRI, and ECG. And I've asked the questions. I've asked you to consider these questions, right? What insights does each test provide about the heart's condition? What does an echo tell you? What does an MRI tell you? And you just need to backtrack to the first lecture in this series of 4 lectures and see if you can apply what we discussed in that lecture to what we've done here, right? And from that, you can make a determination as to which one of these would be useful, which one or more of these would be useful in defining each of these types of cardiomyopathy, and which would be least useful. Okay, and so that brings us to the end of our discussion of diseases of heart muscle. So we started this particular segment, this particular lecture, by kind of reviewing stable versus unstable angina versus myocardial infarction. That was a carryover from the preceding lecture. Then we moved into diseases of the heart valves. We're only focused on the left side of the heart. So we were looking only at the mitral valve and the aortic valve. I discussed both regurgitation and stenosis of the mitral valve, and then you had the information about the aortic valve, and then you had information about the mitral valve, and you can still use the same logic to work your way through that. And then from that, we moved into diseases of the heart muscle, where we started off with pericarditis, and then we went into myocarditis, and then we wrapped it up with cardiomyopathies. And so that wraps up this particular lecture. And what we have left to do is to talk about diseases of the electrical systems of the heart. And that's going to take us through the 4 sort of areas that could potentially result in heart. Anything can eventually lead to heart failure. But those are the 4 big structures that contribute or that helps the heart to pump blood: the vasculature, the valves, the muscle, and the electrical system. The electrical system is the last one that we would need to cover. And then we are going to look at congenital heart disorders. Super, super interesting. And super interesting that they can be, most of them can be repaired surgically. And then we're going to wrap up the whole topic by discussing shock. So what happens if you don't have enough blood volume? What happens if the heart fails? What happens if you've got system-wide vasodilation? That precipitates shock, and that will take us through to the end of this topic. And I'm trying to hit the